In this video, we will talk about medication errors with an example from Florida. A medication error is any preventable event that may cause or lead to inappropriate medication use or patient harm, while the medication is in the control of healthcare professional, patient, or consumer. Healthcare is a risky business. Being in an acute hospital in Florida carries on average a 200-fold greater risk of dying from the care process than being in traffic and 2,000-fold greater risk than air travel. This chart shows how healthcare is too much hazardous than driving and scheduled airlines. Studies have indicated that adverse drug events occur almost daily in medium-sized hospitals and outpatient panels. An example: Mr. J was a 70-year-old man with nephrotic syndrome, pneumoconiosis, and a history of gout and myocardial infarction. He presented to the hospital with increasing bilateral leg edema and pain, for which he had been taking over-the-counter ibuprofen 400 mg 3 times a day for 3 days and once a day for the preceding 3 weeks. His other outpatient medications were simvastatin 40 mg at bedtime, aspirin 81 mg once daily, and metoprolol 50 mg twice daily. In the emergency department, his serum creatinine level was 7.7 mg per deciliter, much higher than the baseline of 3.3 mg per deciliter 11 months earlier. He was admitted to the hospital. After admission, a battery of serologic tests, a microscopic urine examination, and abdominal sonar did not yield specific information about the origin of Mr. J's exacerbated renal failure. Assessing causal connections between agents and disease is fundamental to the practice of medicine and to the understanding of adverse drug reactions. Terms that initially arose from the field of pharmacovigilance, such as adverse event and adverse drug reaction, can help physicians relate the edema and renal failure to ibuprofen. In this case, the treatment and prognosis for Mr. J's renal failure largely depend on whether it was exacerbated by ibuprofen or was due to the progression of his underlying disease. The discipline of pharmacovigilance has yielded tools to assess the likelihood of a causal connection between a drug and an adverse event on a case-by-case basis. These tools address the following criteria: time relationship between the drug use and the adverse event, pathophysiology of the adverse event, competing causes for the adverse event, response to challenge, for example, readmitting the same drug. We use these criteria to gauge the causal link between a drug and an adverse event in terms of 4 discrete levels of certainty: certain, probable or likely, possible, and unlikely. In the case of Mr. J, the timing and the classic pathophysiologic association of ibuprofen with the edema and worsening renal failure may first seem to result in a certain causal association. However, other explanations for the event, such as advancing intrinsic renal failure or cardiac disease, are present, and information on the effect of drug withdrawal is not available at this point in the hospitalization. These conditions result in a possible causality rating, which accurately capture the uncertainty in the causal analysis. The strength of a causal association may be revised as more information becomes available. The day after admission, Mr. J developed painful swollen joints. After sodium urate crystals were found in the synovial fluid, polyarticular gout was diagnosed and prednisone therapy was started. Despite administration of 1 liter normal saline challenge and subsequent high-dose furosemide, the patient remained oliguric with an elevated creatinine level. Before dialysis could begin, he became hypertensive. The metoprolol dose was increased to 100 mg twice a day. Within 2 hours of the increased metoprolol dose, the patient developed respiratory distress and was transferred to the medical intensive care unit, where he was intubated and pulmonary edema was diagnosed. Admitted because of 2 adverse events, edema and renal failure, Mr. J developed 4 subsequent adverse events: a gout flare, hypertension, pulmonary edema, and respiratory distress. Consideration of pathophysiologic pathways and causal associations can also help the physician identify adverse drug reactions in a complex clinical scenario. The basic unit of an adverse event is the sequence of a pathophysiologically related events originating from one pharmacologic effect of the drug. In this case, the presumed pharmacologic effect was the inhibited production of prostaglandin in the afferent glomerular arteriole, which led to decreased plasma filtration. The consequent events of uric acid retention, sodium retention, and fluid retention all resulted from ibuprofen's inhibition of prostaglandin production. In general, a drug may be considered a contributory cause of an adverse event if, had the drug not been administered, the event would not have happened at all, or the event would have occurred later than it actually did, or the event would have been less severe. Ibuprofen may have contributed to the edema and may have exacerbated renal failure. The fluid bolus increased the fluid overload and may have caused hypertension. The subsequent increase in metoprolol probably contributed to cardiac decompensation and pulmonary edema. In contrast, the gout flare is a renal failure mediated secondary or indirect effect of ibuprofen and doesn't merit consideration as a separate adverse drug reaction. Medication error. After spending 2 days in the medical intensive care unit and having several liters of fluid removed by dialysis, Mr. J was extubated and prepared for transfer to the medical ward. Just before transfer, he became tachycardic and diaphoretic. An ECG showed new pericardial T-wave inversions. After consultation with the cardiologist, the intern prescribed 12.5 microgram of tyrofibam. The pharmacy prepared and the nurse administered 12.5 milligram, a thousand-fold overdose. The patient developed a 3 centimeter hematoma on the back of his hand and at a previous venipuncture site and oozing from his dialysis catheter site. He underwent urgent prolonged dialysis and multiple blood laboratory checks. Misreading physician orders and preparing a dangerous dose of a drug is a classic medication error. Such events may be related to professional practice, healthcare products, procedures and systems, including prescribing, order communications, product labeling, packaging and nomenclature, compounding, dispensing, distribution, administration, education, monitoring, and use. Most medication errors do not harm patients. Some authors estimate that less than 1% of medication errors result in harm. Some types of errors may present minimal potential for harm, such as missed dose of simvastatin. Other types of errors pose substantial risk to the patient but are intercepted before reaching the patient. These have been called near misses, close calls, or potential adverse drug events. For example, the nurse who was about to administer the tyrofibam to Mr. J might have noticed that the dose was inappropriate and could have returned the drug to the pharmacy. The day after tyrofibam overdose, the patient reported lower abdominal pain. Since admission, the patient had been taking narcotics and when not intubated calcium carbonate, 1.25 gram 3 times a day. Nursing flow sheets and dietary notes indicated almost daily that, despite eating, the patient had not passed stool since admission. On hospital day 13, the patient was given 1 dose of milk of magnesia and began receiving docosate sodium. The patient responded with 1 small bowel movement. Indomethacin was started, presumably to reduce the patient's narcotic requirements. Several days later, Mr. J vomited and was given droperidol. Otherwise, Mr. J was improving and was charged from the inpatient medicine service to the rehabilitation service. The next morning, the patient had a second bowel movement, 5 days after the first. About an hour later, the patient vomited during breakfast, developed respiratory distress, and was re-intubated. Several days after Mr. J was transferred back to the medical ward, his gout recurred. It was discovered that the intern did not include the prednisone prescribed when she wrote orders for the patient's transfer back to the medical ward. Physicians fail to recognize a majority of adverse drug events for many reasons. Many physicians find the nursing notes difficult to read and may ignore these data, but nursing data may provide the only indication for 40% of all adverse drug events. The failure to recognize an adverse drug reaction as such may lead the physician to inappropriately treat the adverse drug event. In this case, the physician did not pursue a diagnosis for the nausea and abdominal pain, but instead treated the symptoms with droperidol. The pervasive problem of treating each successive drug-related symptom with another medication exposes the patient to additional drug hazards. In this case, the patient was put at risk for sedation, delirium, or cardiac dysrhythmias from droperidol. To avoid multiple adverse drug events, the more appropriate action often is to discontinue therapy with the original drug. Now we come to an important issue about documenting adverse drug events in a way which help us avoid future events. The purpose of documenting adverse drug events in a patient's chart is to help prevent the recurrence of the harm. The more likely an event is to recur and the more serious the event, the stronger the case for documentation and the stronger the incentive to guard against similar use of the drug in the future. Events that are likely to recur are those that have a high causal association with the drug and that result from a common use of the drug. Thus, probable and certain adverse drug reactions are nearly always appropriate to document in the patient chart. For events that are less likely to recur, the physician must consider the seriousness and the nature of the event. For example, a life-threatening possible adverse drug reaction merits documentation. However, documentation is unlikely to prevent the recurrence of an adverse drug event due to an unusual error such as the tyrofepan overdose. These types of errors are better reported through an institution's incident reporting system and dealt with as a sentinel event. Documentation is most likely to prevent future adverse drug events when it serves either to caution against the use of a drug at any dose or to establish practical unsafe dosing ranges. Allergies are common examples of idiosyncratic reactions that make the drug use inappropriate at any dose. But dose-dependent reactions are nearly 8 times more frequent than idiosyncratic reactions. Not including dose information in documentation is a major missed opportunity for injury prevention. Mr. J example, metoprolol was well tolerated at 25 and 50 mg twice a day, but not at higher doses. A second episode of pulmonary edema also occurred after he received 2 50 mg doses several hours apart. Although high doses are more likely to cause adverse events, doses that are too low might also unmask disease. When drugs are suppressing a chronic disease, such as dysrhythmias or seizure disorders, and the disease recurs after discontinuation of therapy with the drug or dose reduction, the unsafe dose should be documented to avoid unmasking the disease again in the future. A meaningful and useful record of an adverse drug event combines all three of these factors: the severity of the event, the causal association between the drug and the event, and the dosing variables. In this case, for example, intravenous morphine at 2 mg 3 to 4 times daily possibly led to severe constipation and probably contributed to nausea and vomiting that resulted in aspiration and intubation. Contributors were calcium carbonate for the constipation and indomethacin for nausea and vomiting. Finally, it's important to document adverse drug events in an accessible part of the medical record. Although many physicians discuss the differential diagnosis of adverse drug events in their progress notes, they may note only the drug name in the allergy section of the chart. A more detailed description in the allergy section may help another physician decide whether subsequent use of the drug is contraindicated. And here is an ideal example of how to document the adverse drug events in our case. For ibuprofen, in the dose, we wrote 400 mg 3 times daily. In the causation, we put possibly exacerbated renal failure with creatinine level increasing from 3.3 to 7.7 mg and 3 plus edema. For metoprolol, we wrote 100 mg twice daily, probably precipitated congestive heart failure and respiratory failure within 2 hours of the increased dose. Once in the setting of renal failure, fluid overload and aspiration, and once in the setting of aspiration alone. Metoprolol 25 to 50 mg twice daily was well tolerated. For intravenous morphine, 2 mg 3 to 4 times daily possibly led to severe constipation and probably contributed to nausea and vomiting, resulting in aspiration and intubation. Contributors were calcium carbonate for constipation and indomethacin for nausea and vomiting. And for indomethacin, we wrote 50 mg 3 times daily possibly led to gastritis and nausea and vomiting, resulting in aspiration and intubation. Prednisone may have contributed to nausea and vomiting. On the other hand, the hematoma from tirofiban overdose and the gout recurrence from inadvertently discontinued prednisone are medication errors that should not be documented in the adverse drug event section of the patient medical record. Mr. J's respiratory status rapidly improved and he was extubated the next day. Shortly after he had a dark guaiac positive stool, therapy with indomethacin was stopped. 2 days later, and hours before anticipated discharge, the patient vomited and aspirated his breakfast. He developed extensive bilateral pneumonitis and pneumonia. Mr. J died the next evening. Thank you.